Is that the question that someone asked earlier?
I think the current process should be matured to be more consistent, and this is Ann Wells, the Bureau Chief, to be more consistent with how the Bureau handles prior authorizations for other classes of medications. We do have a number of children on continuing therapy who will need to be reviewed in the fall, and so the volume of work that could potentially be routed to our clinical consultants is pretty significant.
Sure.
And that's really the reason why we wanted a commitment from the committee to help us build a more independent process to handle the review except for more extenuating circumstances. And as I said before, the pharmacy clinical team here manages prior authorizations for multiple classes of medications based upon written medical criteria that exists in the medical literature. And because the medical literature is a little thin in this category is the major reason we plugged in the psychiatrist consultants.
Okay.
Does that make sense?
Yes.
Okay.
Yeah, this is Lisa Cosgrove again. I think, because the Academy of the Florida chapter AAP is also having meetings regarding children's mental health, and we have discussed these issues before, that it's not an exact science, and every child is unique and individual. Obviously, that we know that there is an indication for medication in the autism child from age 3 on up. Other than that, most pediatricians, and I'm speaking now as a pediatrician, would refer our great esteemed colleagues, the children's psychiatrists, to make those decisions of whether they think a medication would be valuable for the benefit of that patient or not. And I think that most, in my experience, our child psychiatrists around here are very good about using appropriate medicines first and then graduating to medications that seem to be more of the atypical type. And other child psychiatrists on the lines can correct me if I'm wrong.
This is John Lalekis. I'd like to ask a question. In looking at the comprehensive report of atypical antipsychotic prior authorizations through 2 dates, April the 25th through June 19th and April the 25th through June 12th, what I saw was that the provider types was something that I looked at and I sort of questioned, only because I certainly concur with Dr. Cosgrove in that particular procedure that they have. I felt that was the prudent way to go. When I look at and I see others that may not be as familiar for children under the age of 6 to prescribe these atypical antipsychotics, I'm sure the situations there that do exist. However, I was questioning the provider types, whether all the provider types there should in fact be prescribing that medication without a referral from either a pediatrician or another person. I looked at the other category, which was also, to me, a pretty high statistic there. You had anywhere between 14.4 and 15.3% categorized as other, yet we put family practitioner with 1 each time. So, I'd like to know what other is as well, because here again, we're dealing with children under the age of 6. Not that the medication isn't something that should be considered. However, my question is, are all the provider types trained enough and qualified enough to, in fact, prescribe atypical antipsychotics?
This is Lisa Cosgrove again. When I'm looking at those data, the pediatricians prescribing, I'm not sure if that would be, I think you need to divide that out into initial prescribing and to continuation prescribing, because many times myself as a pediatrician practicing, may write medicines for patients that are already on medicines just because they can't get into their psychiatrist on time. but it doesn't mean that I have made the diagnosis and that I am actually treating that child for that. I'm just helping them out until they can get back to their psychiatrist, because as we know, the state does not have enough child psychiatrists to go around.
I just want to jump in on the agency perspective. I don't think that we have the ability to judge which providers are more qualified than others. We did the tabulation. What we found is that most of the prescriptions are written by child psychiatrists, by neurologists, and by pediatricians, and that's consistent with what I think Dr. Cosgrove is saying. But to take it further past the tabulation, I don't really think we can do that.
Hey, this is John Malekis again. If there's no FDA parameters on this, I think it sort of gives us an opportunity to create parameters. And that was my question about the provider type. If, in fact, the FDA doesn't specify them, should we not take a proactive approach in actually determining which provider types? And here again, I would like to see the other further delineated to who other is. I mean, if we can say family practitioner is 1, and we have other as 56, that's 14.4%. I mean, shouldn't we have an idea who the other is?
We can have our analyst go back and itemize that.
I would appreciate that. Thank
Sure.
you.
This is Rich Thacker. I'm an internist, but represent the FOMA, and we have a large percentage of primary care physicians. But I would say that I think it is within our parameters to limit some of the prescribing. And a case in point would be such as an HMO or any other insurer can decline to authorize certain medications or certain treatments or even certain diagnostic treatments. Let's say if I want to send somebody to the sleep lab because of obstructive apnea, many insurances may say, well, this person has to be evaluated by a pulmonologist first or whatever. And so that's part of it is cost control, but it's also some quality control, and certainly I may resent that at times, but I think it's within our parameters to do that. So I would certainly be in favor of limiting new prescriptions, but taking into account Dr. Cosgrove's comments, I certainly agree as well as a primary care physician that many times we have to renew medications that have already been started by specialists, and we may not want to do that routinely. I think that occasion comes up fairly often and is a benefit to our patients and their families, and in fact a benefit to the specialist because of just accessibility. And then one last comment along the same line about the other could be that we're seeing more and more in joint residences that have internal medicine and pediatrics together. So we may find that we have an internist slash pediatrician.
This is Lisa Cosgrove again. I don't know, in this committee, are we going to be making motions or anything like that on what we should be following? But I do remember a conversation that I had at a national pediatric meeting where we actually talked about psychiatric issues in children all ages, where there was not a single pediatrician in the room that felt comfortable in the primary prescriber of atypical antipsychotics on just about any age child. And they felt very comfortable with getting our esteemed colleagues, the child psychiatrists, to do the diagnosing first and helping out with the treatment plan. And then pediatricians were comfortable after that as long as we knew what the treatment plan was. So if we could make a motion here, I would certainly see that it would be appropriate to have medications prescribed to this age group only if they have been evaluated first by a child psychiatrist. Or neurologist, I think, would also be appropriate, especially if it is in relationship to certainly autism or it seem appropriate there. So I don't know if we can make a motion or not, but you could tell me.